We are live. We can start with the session.
Okay. Hello, good evening, everyone. A very warm welcome to this special Facebook live session brought to you by the Endocrine Society of India. So, I am Dr. Vibhu Ranjan Khare, Assistant Professor of Endocrinology at MLN Medical College, Prayagraj. So, our topic is one that touches millions of life across the country and the world. So, we will be talking about the medicines for obesity, the hope, the hype, and the reality about these drugs. So, obesity is more than just a number on the scale. It affects our weight, affects our health, our energy, and even how we feel about ourselves. So in India, last year, semaglutide and tirzepatide were launched. So there has been too much hope, too much hype about these drugs. So with so much information floating around, it can be hard to know what to follow, what to believe, what not to follow, what not to believe. So especially when it comes to these drugs, because there's so much precautions associated with these drugs, so much to know before starting these drugs. So that's why we are here today to cut through the noise and to give you clear, science backed answers directly from the expert. So, joining us, we have someone from the endocrinology who needs no introduction. We have Dr. Amrish Mittal, sir. Sir is a group chairman of endocrinology and diabetes at Max Healthcare Delhi. So, sir will understand how these medications work, who they are meant for, when they should be given, when they should not be given, and what precautions should be followed. So, hello and good evening, sir.
Hello, Vibhu. Sorry.
Good
Yeah.
evening, sir.
Good evening. Yes.
So, sir, we will be starting our talk on these newer drugs for related to obesity. So, there will be certain questions which will clear certain myths about that, certain hype about that, certain hope about that, what to do, what not to do, what to follow, what not to follow. And, sir, who can be better other than you to guide the country about this, sir? So, sir, first question which I'll be asking that if people do ask this, that if they are started on these drugs, whether they will have to take these drugs forever or whether they can stop it after some time.
Thank you, Vibhu. It's a pleasure to be here with all of you. Quite looking forward to this discussion. You know that tirzepatide and semaglutide, which are commonly available as Mounjaro and Wegovy or Ozempic, are GLP-1 drugs. And these drugs act by the GLP-1 pathway, which means that they suppress, in addition to controlling our diabetes, they suppress our appetite and they also improve our satiety. And therefore, these drugs have crossed the 15% barrier, which means you can lose more than 15% of your baseline weight. What does it mean? If you're 100 kilograms, you can probably go to 80 or 85 or even less, actually, sometimes. So, these are the two drugs. Now, obviously, when we think of obesity as a disease, and we think of treating it with medication, one of the first things that I already said is about, are they efficacious? Yes, they are efficacious. That's proven beyond doubt. Semaglutide maybe 15-18%, tirzepatide 20-22% of baseline body weight, particularly in those who don't even have diabetes. And the other aspect there is of side effects, which I'm sure will be discussed. But
Yes.
very important question you very rightly said is, when you start treatment for a chronic disease, if you think of obesity as a disease, which is how WHO classifies it, then how long to take these drugs for? You know, you take antibiotics for 3 days, 5 days, sometimes for 2 weeks. You take antitubercular for 6 months, maybe. Uh, but what do you do with medicines like anti-diabetics or your blood pressure medication? Chronic disease doesn't just go away. And if obesity in your case has reached the stage when it can be called a disease, then it is very likely that you may require at least some maintenance dose for very, very long time. Now, the issue here is that there are some people who are on the borderline, sort of, in terms of weight, in terms of indication, and they work very, very hard with their diet and exercise. And then when they are put on these drugs, they use these drugs as a kickstart, as a way to kickstart their future plans. And such patients who are not like coming with BMIs of 40 or 45, they may be able at the end with gradual tapering to go off this medication. However, if you're taking these drugs for severe obesity, if you're taking these drugs for obesity with diabetes, with fatty liver, comorbidities as we call them, with all these accompanying disorders, then it is difficult. Like you, it's difficult for you to discontinue your diabetes drug, because the fundamental principle is every drug works for as long as you take it. Now, to further explain this, think of all your patients or all of you as people who have tried weight loss diets, very severe weight loss diets. You went on a keto diet, you went on a starvation diet, 800 calorie diet. The diets seem to work only till you're able to follow them. The moment you lapse back into a normal diet, you'll again get into the same situation. Therefore, these are long term drugs. In the more diseased people, more abnormal people, they can even be lifelong or very long. In the mildly diseased people, or those who have borderline cases where they're crossing the line and that's why you're starting them, and who are able to modify their lifestyle very substantially, such people some of such people may be able to go off the drug.
Okay, okay. Thank you, sir. Sir, there is also a myth that people think like if we have started on these drugs, there is now no need to exercise or diet. कि अब तो दवा चल रही है तो अब diet और exercise क्यों करना? Weight loss तो दवा से हो ही जाएगा. So is that true, sir?
Yes, if you look at weight loss as the only criterion, yes, you will lose weight even if you don't do anything. Even if you just let the drug dictate your life, even then you lose some weight. But if you're looking at anything more than that, if you're looking at enhancing your weight loss, number one, number two, if you're looking at preserving your muscle, if you're looking at some point tapering the dose, or actually managing your health rather than your cosmetic weight, then you absolutely have to follow diet and exercise plan. In fact, those patients who seem reluctant to do that, we do not allow them, we don't prescribe these drugs. You have to commit to a structured diet plan, which includes enough protein, which includes enough fiber, proper hydration, and at the same time, you need to commit to exercise, especially strength training, weight bearing exercise, which is a muscle building exercise, because when you lose weight fast, you also lose some muscle. So, unless someone is really doing this, they may be harming themselves actually, because then what you're doing is you're losing weight, you're losing fat, you're losing muscle, and at the same time, you're not doing anything to preserve the muscle. You're not making sure that your nutrition is okay. So, in one line, these drugs are not individual independent tools. For your health, it is important to practice diet and exercise along with these drugs. Otherwise, you will not only not get the maximum benefit, you might even harm yourself.
Okay, okay. So these three things are the drugs, the exercise, and the proper structured diet plan go hand in hand in a synchronous way.
Yes.
So, sir, so if somebody is started on these drugs, so is it that the effect is apparent from the very first week, or does these drugs take more time to show the visible effect?
Well, it takes a little time. And some patients may suddenly, because they stop eating, or their appetite gets hit even with the first injection, they might feel even a weight loss in the first week. But classically, no. Classically, the weight loss we should measure at the end of 1 month. Even there, many patients show very limited weight loss. There is a small proportion that shows significant weight loss even in 1 month. But most of them show limited weight loss. And then the principle on these drugs is to start with the lowest dose and build up gradually. So if you are starting with the lowest dose and building up gradually, you obviously, it'll take time to respond. And in any case, it's better for us if we take a little time and not completely sort of sudden, rapid weight loss, it's probably better to do it stepwise. But the main reason for going slow in the drugs, why don't we start with, say, 15 milligram tirzepatide or 2 milligram semaglutide right away? The main reason is the tolerability. So, if you want to tolerate these drugs, or if you want your patient to tolerate these drugs properly, you will have to uh, start with very low dose and build up very gradually, and that's the correct way of doing it. Otherwise, you will not be successful in what you set out to do.
Okay, sir. Wonderful, sir. So, sir, these drugs were initially approved for the management of diabetes. Now they are being approved for the management of obesity as well. So, can someone who is obese but is not having diabetes, can he or she take that drug? Won't it lead to hypoglycemia or low blood glucose in them? Somebody having obesity but no diabetes, can those patients take these drugs, sir?
ये नहीं चला और इसका इसका भी चार्ज नहीं हो रहा है वहां से. Sorry, it got hung. I don't
Ha.
know.
Sir, I'll repeat my question. So
Yeah.
these drugs were initially approved for the management of diabetes, these group of drugs. So later on, they are now also have been approved for management of obesity. So if someone is obese but is not having type diabetes, so can he or she take these drugs? Won't it lead to low blood glucose or hypoglycemia in them, sir?
So the first thing is that the drugs, yes, were initially developed for diabetes, but it does not mean that they cannot be used without diabetes. The idea is that if the drug is developed for diabetes, uh, primarily because it increases insulin secretion and reduces gastric motility, which reduces postprandial spikes, but it also has a considerable effect on the appetite. So when originally this class of drugs, which is more than 20 years ago, were launched, then they were primarily anti-diabetic drugs with some additional benefit of weight loss.
Yes.
Now their action on the insulin is dependent on the glucose level. So they do not produce low blood sugar when used on their own. Their action stops at, say, 70, 80 milligrams, their action will stop.
Okay.
Now, over the years, when it was realized that the weight loss action is hugely beneficial, not just for diabetes, which also has helped a lot if you lose weight, but also for a host of other conditions. Good examples being cardiac disease, blood pressure, fatty liver, different types of arthritis, even some types of cancer. So if you're looking at it like that, that weight loss is important for these, scientists tried to modify the molecules to reach a stage where they could produce much more weight loss, which means much more brain action, because it's the brain action that is the primary driver of the weight loss.
Yes, sir.
Anyway, without confusing you, the important part is that the newer molecules in this produce considerable weight loss, as we have said, along with controlling diabetes. Since they do not produce low blood sugar, and since the benefits of weight loss, independent of the effect on sugar, are very significant, and since we classify obesity as a disease, therefore, yes, they can be used in people without diabetes also. It's not wrong, it's approved worldwide. Only thing is, typically, we use in little heavier people without diabetes. And those who have comorbidities like diabetes and other things, we can use, let's say, a BMI of 27. Whereas in those who don't have anything else, just weight, a BMI of 30 is considered appropriate.
Okay, sir. So, sir, nowadays, sir, like many reproductive aged females come and say that that they are planning for pregnancy, so they want a healthy baby, they want a healthy pregnancy. If they are obese, they say that can we use these drugs during pregnancy, or if they are already pregnant, can they use these drugs, these GLP analogs, if they are planning for pregnancy or if they are pregnant?
So this is the perhaps the most difficult question about these drugs. Some of the parts of the question are easy. You don't use them in pregnancy, right? That's a given. The challenge is that we get a lot of women, girls with polycystic ovarian disease, PCOD, as everyone knows, where weight is the primary driver of their abnormal status. Now, their losing weight is therapeutic, and losing weight can help you improve your fertility. So, therefore, weight loss is treatment there. So, you do use these drugs for weight loss. Supposing it's a 80 kg lady, 85 kg girl who wants to conceive, who's married now but is not getting her periods regularly, lots of other issues, then we always say you must lose weight. Now, with these drugs, she can lose 10, 15 kilograms of weight. Her cycles may return and she may be much more likely to get pregnant now.
Yes.
The challenge, however, is that the safety in pregnancy is not proved yet. So you have to stop the drugs 2 months before you plan pregnancy. The
Okay.
problem again doesn't end there because with polycystic ovarian disease, you may not conceive for those 2 months.
Mm.
And when you go off these drugs, the weight starts increasing. And then during pregnancy, also the weight increases. So it is a bit of a question mark. In such cases, it is short term use to lose weight and induce menstruation and improve fertility. During pregnancy, the drug should not be used. It has to be stopped before that.
Okay, okay, sir. So I think, sir, with time, maybe we'll have a better idea.
Yes.
Maybe it can be later approved. Maybe with time, with trials,
So,
we'll have better
so,
idea of
so anecdotal reports, Vibhu, I'm sure you're aware that there are anecdotal reports where patients took by mistake,
it. Mhm.
or they didn't know they are pregnant, or they didn't know they're supposed to stop. All the results so far have been safe.
Yes, sir.
But still, in pregnancy, to label something as safe is a challenge. No?
Okay, okay, sir. Thank you, sir. So, sir, usually the nowadays, sir, this childhood obesity, adolescent obesity, that is increasing a lot. So, suppose a sir, mother comes with a child of around 8 years, 9 years, and she's worried that her child is very obese, and she has heard over the social media somewhere that these drugs have come in the market and are very effective. So, can that boy of 9 year or 8 year old be given that drug at present, sir?
So, remember, these drugs do curtail your diet very significantly. And that's a growing age.
Yes, sir.
And you don't want nutrition to be compromised in any way.
Yes, sir.
So calories are very important for your growth, whatever the weight might be at that point. So unless someone has real pathological obesity, nowhere in the world one uses these drugs at with 8 9 year in 8 9 year olds.
Okay.
Yes, in the US they are approving for above 12 Munjaro, obese children, type 2 diabetes, and all that, young obese type 2 diabetics. But in general, one has to be really cautious. So while if pushed to the wall, if obesity is making the child's life impossible or very difficult, then one can consider. But I would say at the moment, I wouldn't rush to treat childhood obesity with these drugs.
Okay, okay. Thank you, sir. Thank you. So, sir, if somebody is a known case of type diabetes and is obese, and if we are planning to start that person on these drugs, and the patient is also having diabetic retinopathy, so can semaglutide worsen it? And can we give in that condition? And what are the other conditions where we should avoid giving these drugs?
So I think that I would avoid it in proliferative diabetic retinopathy. Not all. If you have a few dot blot hemorrhages or a little bit of, this thing, but if you clearly have proliferation, neovascularization, etc., then I would avoid the drug. So active proliferative retinopathy is the reason to avoid. And why is that? It's not because it's harming the retinopathy. It is thought very much like when we introduce intensive insulin treatment in such patients, you rapidly correct the sugar. And you rapidly correct the sugar, then you may worsen the retinopathy because of the changes in the viscosity and the flux and the vascular flow. So therefore, it is important that everyone has an eye check before starting. And if somebody has active proliferative retinopathy, they are not the best candidates to use these drugs in. I would avoid that. There are other conditions also. If someone has clear history of pancreatitis, I would avoid these drugs. If someone has a family history of thyroid cancer, I would avoid these drugs. So all these are important contraindications. One has to be clear if there is, it's not a written contraindication, but definitely patients with inflammatory bowel disease who have recurrent GI problems, all those things. I would be cautious. I would be cautious. Tell the patient, follow them up carefully, and only then you can consider using.
Okay, okay, sir. Surely, sir. So, sir, suppose some two young males come to your OPD, both were started on one of these drugs at the same time. So they come after a follow-up of 3 months. One has lost around 7 kgs, the other has lost only 4 kgs. So the person who has lost only 4 kgs is worried. And he asks whether that drug is not working on me or why is it not effective on me. So, sir, why is that difference in inter-individual difference, sir?
So this is another one of the biggest questions right now. We are not able, we will only be able to distinguish responders from non-responders in a predictive kind of way when we are at a level of precision medicine. That is true for most medicines. Some people respond to telmisartan 20, some people respond to telmisartan 80. I'm just saying. So there is a lot of variation. Definitely, and it happens to me all the time. Husband and wife both on the drug, and the husband has lost 14 kg the other day. I saw wife lost 3, and same food they're having at home. Everything is same. So I think there is a lot of individual variation. There are a few points in our own data which we have just getting published in IJEM. It must be online now already. Number one is older age patients lose less weight, younger patients lose little more weight. Number two, those who are diabetic lose less weight, those who are non-diabetic lose more weight.
Yes, sir.
Number three, those who have used GLP-1 drugs in the past or who are transitioning from one kind of dulaglutide or liraglutide or even oral semaglutide to these newer drugs, their weight loss is also not, it doesn't add up that you lose 10 kg with semaglutide and 10 more with tirzepatide. It doesn't work like that. So these are the predictors that we have, but obviously there are many more and we don't know that. No one knows. Science doesn't know yet.
Sure, sir. Time will, I think, explore all these things,
Yes,
sir.
that will come out. Yeah.
So, sir, so somebody suppose is on since liraglutide was launched way back. So, if somebody was already comes in the OPD and says that I have been on liraglutide for since long time, and he has heard that tirzepatide is much more way effective than liraglutide. So, can he switch to this tirzepatide? Is it possible, sir?
Yes, you can switch. You can definitely switch. You will get little better response, but remember, you won't get a dramatically superior response.
Yeah.
That's exactly what I was saying. But yes, you will. You can switch, of course. We have switched many patients.
Okay. Okay. Sure, sir.
But
So,
again, when you are
yes, sir.
switching, your starting dose, you got to be cautious about,
Mhm.
because someone is on these drugs. You can't start with a high dose of the newer drug. You have to
Yes, sir.
again start with low dose, whether the lowest or a little higher than that, but on the lower side. So, for example, you can't start anyone on 10 milligram Munjaro or tirzepatide.
Tirzepatide.
You do 2.5. If someone has really used it a lot, other drugs, and is perfectly fine, you can start with 5 if you want to be very bold, but you can't go above that. Similarly, with semaglutide, you can typically start with 0.25. Maybe in those who have used, you can, and tolerating well, you can start with zero point 0.5, but that's it.
Okay. Okay. Sure, sir. So, sir, like people also come and say that they have read over the net or they have heard from someone they know who is taking these drugs that certain gastrointestinal side effects like nausea, vomiting, bloating, diarrhea, these are very common with them. So, sir, how much is the percentage of people who experience these side effects and how to manage these side effects, sir?
So these side effects are quite common actually. Some degree of GI side effects happen in at least 50% of people. So, and they include nausea, of course, some feeling of indigestion, nausea, sometimes reflux. Some people get constipation. Constipation can be very disabling for some people. It can really bother them. You make aggravate a fissure or those kind of things. Uh, some people get diarrhea. Secretory diarrhea is also known with this. So all kinds of GI side effects are possible, but there are two, three important things. Number one is that these side effects are usually manageable by regular things. Acidity, use pantoprazole; diarrhea, use Imodium. Like that it goes. So these are manageable side effects. Number one. Most of the time, if you're really good with your food and dosing, you'll get much less side effects. If you really follow what has been advised, small meals and a little bit of walking after meals, you follow all those things, then actually you will get less side effects. And the third and very important thing is that they're usually transient. Over a period of time, they just fade away.
Okay.
So you don't keep getting these effects. First couple of months, maybe every time you increase the dose, but after some time they just settle. Not a problem.
Okay. So I think it's a proper counseling of the patient and the realistic, like the patient should be told beforehand that you may have experienced these side effects because they are very common.
Absolutely, yes.
Okay, okay, sir. So, sir, lastly, we will be discussing on certain questions, which will be like take-home messages also. So, suppose a patient comes who is a known case of type 1 diabetes and and is also obese. So he comes up and asks that can he take this drug for losing weight? Sir, is it possible?
So it's not an approved indication. The question is about type 1 diabetes who become obese, which is not unusual now in our practice. But
Okay.
when we are stuck with type 1 diabetes or obese and they're fluctuating and the insulin demand is going up and sugars are all over the place, it, as an expert endocrinologist, Vibhu, you can use these drugs under your supervision. They are not to be approved generally, and I don't recommend it that people try to stop insulin and use these drugs. That is very dangerous. What you're
Yes.
doing is in type 1 diabetes that has obesity also has insulin resistance, and
Yes, sir.
obesity itself is causing problems, and the weight itself. And therefore, there, in addition to insulin, on top of that, you can add, and this will bring down the insulin dose and smoothen out the control. So it can
Okay,
be
sir.
considered.
Okay, okay, okay. So it has to be under supervision, but it's
Yes,
not
of an
like
expert, of
of
an
an expert.
endocrinologist.
Sure,
Yeah.
sir. Okay. So, sir, we also have in the market oral semaglutide. So, sir, is it also like this oral semaglutide also effective and is it equally effective as compared to the injectable one? Can this also be used, sir?
So oral semaglutide is fine. It's the same thing. It's semaglutide. It's just a way of delivering the drug. So oral is a lower dose, reaches your bloodstream. With injectable, a higher dose reaches your bloodstream.
Yes, sir.
So with injectable, you can go much higher. When you're looking primarily at diabetes control, then oral semaglutide is very good. It generally doesn't produce a degree of weight loss that we expect with injectable because the blood level is much lower, the dose is lower.
Lower.
As simple as that. So otherwise, it's a very good anti-diabetic drug.
Okay, okay. Sure, sir. So, sir, if somebody supposes losing weight of around considerable amount of weight, 15%, 20%, so will this weight loss be entirely fat loss or will there be a loss in the muscle mass and the bone mass also?
So every time we lose weight, whether it is with GLP-1 drugs, whether it is with diet alone, whether it is with bariatric surgery, we also lose good 20-30% of the weight goes as muscle. So, you lose that much weight, that much muscle always. So it is important to minimize that. And the way to minimize that is to follow a protein-rich diet and strength training. And because why is this suddenly being talked about? Because there was no way to lose weight so rapidly and so substantially for years. And now we have these tools which make us lose weight so fast. And if that is happening, then definitely you will also lose muscle. If you're really careful, you can minimize that loss, maybe 10%, 15%. And if you care less, and you will lose up to 40% of your muscle mass. So not 40% of your total mass, sorry, you understand it clearly. Of the total weight lost, typically the muscle part is 20 to 30%. So in 10 kilograms, 2 to 3 kilograms.
Okay. Okay.
So now that, if you're very careful, you can bring it below 2 kilograms, maybe 1.5 or even 1 kg. If you're not good with your diet, not good with the exercise, you may lose, out of the 10 kg, you lose 4 or even greater maybe than muscle. So that's very high.
Okay. Okay. So the people have to be cautious about that, and diet and resistance training will play an important role in this. So lastly, I'll end this talk by asking the last doubt, or you can say last myth, that if somebody has started taking this drug, will he or she continue to lose weight, or will this effect play to after some months or a few years?
Yeah, but that is the story of obesity treatment. It does plateau after some time. The only thing is, in classic obesity models, weight loss plateaus at 6 months or earlier. But with these drugs, you can continue up to a year, year and a half, 72 weeks, as they say. So you can go that long. So, but ultimately, it will plateau. So those who feel, and the celebrities and all who keep saying, "Okay, I keep losing," and all, you will stop losing at some point. That
Okay.
point will be between 1 and 2 years.
Okay. Sure, sir. So I think our audience and viewers have got almost all their doubts cleared. So they must now be knowing and understanding how these drugs work, how like when whom they should be given, when not to give these drugs, and what precautions should be taken, what adverse effects these have, and they should always be given under strict supervision and not to be prescribed to everyone. So, sir, as a take-home message to our audience, what would you like to say in the end, sir?
I think we should not be wary of these drugs. We should not be fearful. These drugs are a huge scientific advance. They're going to change the way that we look at chronic disease. That's the plus side. The minus side is that they have side effects, and they can only be taken for the right person, under the right supervision, in the right dose, at the right time. You have to do those things. You can't start using it like a Saridon for headache. That's very important to understand. And if you use them judiciously, under proper guidance, these drugs can change the profile of metabolic disease in you, and those near and dear to you who are suffering from these problems.
Sure, sir. Sure, sir. So, obviously, these drugs will be a game changer in many of the metabolic diseases. But yes, diet and exercise will be an important part, will be playing a synchronous part with this. And certain famous personalities like Oprah Winfrey and Elon Musk, they have used these drugs and also have officially accepted. But yes, diet and exercise have to go on. If I could remember Elon Musk when he tweeted this, so his tweet consisted of three words: fasting and Wegovy. So he also wrote that yes, fasting and important diet plays a very considerable role if you want to see a good effect of these drugs. So yes, we had a wonderful discussion today on these newer anti-obesity medications. What are the myths associated with that? What were the doubts associated with that? And I hope the audience is clear with everything. Thank you, Dr. Amrish Mittal, sir, for taking out time for this wonderful session. Thanks a lot, sir. Thank you.
Thank you, Ibu. Thanks a lot. Enjoyed it.
Thank you. Thank you, sir.